I want to introduce Dr. Sanjeev Arora, who has joined us. Dr. Arora is the director and founder of Project Echo. Sanjeev?
Yeah, first of all, I'm really honored to meet all of you, and thank you for joining this session. As has been previously mentioned, I'm a great admirer of the people who work in nursing homes. We are truly inspired by your commitment to take care for the sickest people in this pandemic and to stay engaged and coming to work every day despite some of the risks so your colleagues have faced. And so thank you for that on behalf of us. But I really want to request you to sign up because we are very keen to collaborate with you, and we believe the project can save many, many lives in the United States.
And so without further ado, I will introduce our first speaker, who's Dr. Kedar Mate, who's president and CEO of the Institute for Healthcare Improvement. Kedar?
Thank you, Matt. It's a pleasure to be with all of you. Thank you for joining us here today. As Matt mentioned, my name is Kedar. I'm the president and CEO of IHI, the Institute for Healthcare Improvement, a leading quality and patient safety organization here in the US. And we're pleased to be partnered with AHRQ and the Echo Institute to bring you the National Nursing Home COVID-19 Action Network. My job here in the first few minutes is to share a little bit more information with you about the Action Network and how you can get involved in it, what its goals are, and help you make the decision that we hope you'll make to join us in the Action Network going forward. You've already heard from me. You'll hear from Alice Bonner, who works with us at IHI and formerly worked at CMS, leading our nursing home work, and you heard already from Matt there in the middle. So what is the COVID-19 Action Network? It is a program of work supported by AHRQ, the Agency for Healthcare Research and Quality. We're working together with Project Echo and with the IHI ourselves, and we are launching this network together. We are in the process right now of recruiting nursing homes from around the country to join in this community of practice. And we'll share a little bit more about it as we go through this morning's conversation. The goal is to advance our work in COVID-19 and to be more prepared for COVID-19, to face COVID-19, to ensure or improve patient safety or resident safety in our institutions, and to improve infection prevention and control to prevent the spread of COVID-19 in our communities and in our nursing homes. We know this has been a very challenging period for many of you. We thank you for the work that you're already doing to try to prevent and mitigate the impact of COVID-19 in your institutions at this time. And we know that the consequences for our residents and our families that come and have individuals that are residents in our nursing homes are quite dire. So we recognize that. We also are recognizing the enormous work and efforts of your staff, and want to recognize that and thank you all for the work that you're doing, and then share with you how this program will help you to further combat the challenge or face off against the challenge of COVID-19. The goals of the program are listed here on this slide. The ultimate goal, the overall goal, is to implement the best available evidence that we have today about what it takes to mitigate the impact and reduce mortality from COVID in our nursing homes. There are 6 sub-objectives, if you will, that we have been reciting now as the primary aims of this initiative. Number 1, keep the virus out of our institutions, out of our nursing homes where it hasn't entered, to prevent it from taking place in the first place. 2, identify residents and staff who have been infected by the virus as soon as we possibly can to, again, mitigate the impact of the virus in our environments. Number 3, prevent the spread of virus between staff, residents, and visitors. As we begin to open our institutions to visitors more and more, how do we do that safely? How do we do that effectively? How do we make sure that we protect our staff and our residents going forward? Number 4, provide safe and appropriate care. If you have infected residents with mild or asymptomatic cases of COVID-19, how do we provide best possible care to those individuals so that we can ensure that they recover safely and to the best of their ability? Number 5, make sure our staff are safe. Ensure staff safety, ensure staff practice key safety measures that not only protect the residents, but also protect themselves from COVID-19. And then lastly, and critically, as I mentioned earlier, we are starting to create avenues for resident engagement with their families and with other residents and other staff. How do we do that safely? How do we work together to reduce social isolation for residents, families, and of course our staff as well simultaneously? Those are the overall objectives of this COVID Action Network. How will we achieve those goals? There are essentially 2 primary mechanisms through which we imagine meeting those goals. One is to provide at no cost. There's no cost, and as we'll mention in a few minutes, there may even be some economic benefit to you, but there's no cost to this training. There's no cost of participation in the program from a financial perspective. Of course, there's time, and your time and effort is extremely valuable, and we recognize that. So we're doing our best to try to minimize the amount of time and yet create opportunity for engagement and understanding around how we can, and answer questions around how we can take on the challenge of COVID-19. So this is a no-cost training and mentorship program to ultimately thousands of nursing homes. The goal is to reach everyone, everywhere in the country with this program and with the resources that we are creating. We are creating a virtual learning community. We live in now a digital world and a virtual world increasingly, and so this will be a virtual program whereby the nursing home teams and staff can learn from experts from CDC, CMS, AHRQ, a variety of other sources. Will bring the best available information on what it takes to take on the challenge of COVID-19 to you. And we'll also be hearing from each other. We'll hear from nursing home organizations that have taken on, in a very practical way, translating those pieces of evidence into practice. We'll be hearing from them so that we can address these issues and implement those best practices in your care environments. The approach that we're taking, as I mentioned a moment ago, is an interactive virtual community. This builds on the ECHO model, which is a very interactive model in which expertise is delivered, yes, but we also work in an environment of all teach, all learn, which is both important to Project ECHO and to IHI, in which everyone has something to teach each other over the course of this effort. There will be weekly sessions over a 16-week period that will include a short didactic component in which we will deliver a nugget of best practice, as we will do in just a few minutes here with Alice's talk. And then we will start to work through your cases, your real practical examples of how you're trying to take that evidence and apply it in your nursing home. And that case-based approach is where I think the richness of this program really comes through. It's where what distinguishes it from other learning models that are out there right now. It's very practical, it's very tangible, it's very focused, and it's really trying to help us address the problems of evidence translation into action. Nursing home teams will learn from experts, of course, but they'll also learn from each other, as I said earlier, and those specialists that are doing the work on the ground. And then ultimately, the goal is to be readily implementable and immediately implementable. The approach that we're taking is, again, as I said earlier, is virtual. There will be small multidisciplinary teams of subject matter experts and quality improvement experts. The quality improvement aspect of this is the implementation methodology that we'll be coaching you through to help you implement or translate the evidence into practice. Nursing homes that elect to participate in this, and we hope that will be all of you, will join groups of somewhere between 30 and 35 nursing homes per cohort. You can see that there on the slide. And they'll follow a sort of standardized curriculum that is updated to reflect any new science, any new evidence that's coming through. So as we ultimately right now, a big question for us right now is around testing, which is why we had a webinar on testing that Matt described at the top of the hour as test kits and testing machines go to nursing homes right now, flow to nursing homes. But of course, what challenges us on a weekly basis around this pandemic changes. And as a vaccine becomes available, there'll be questions about vaccine implementation. And as the next challenge becomes available, there will be new future challenges. So the curriculum is intended to be adaptable to the environment and to the currents that we're facing in our care for patients with COVID and for preventing COVID from entering our institutions. We will have over 100 training centers that Project ECHO will be bringing into this that will help to coach each of these cohorts of 33 to 35 nursing homes, and will establish that local learning community that will help to stimulate each other and support one another. These are some of the highlights. I won't belabor this. There's a number of elements to the curriculum: how to work with your PPE, how to manage infection control practices more effectively. I mentioned COVID-19 testing, how to do testing well, how to interpret the results of those tests, et cetera, how to manage the results of those tests as you get positives and negatives back. What do we do? How do we manage that effectively? Clinical management of mild or asymptomatic cases of COVID-19. How do we minimize the spread? How do we manage social isolation? And many other similar topics that will evolve over time. Who should join us? Every nursing home in the country should join us. And why? Because you will gain through this effort practical information, skills, the latest available knowledge on and translation of the science into practical, usable, implementable tools. We're developing a library of resources, a playbook that will help you with implementation. You'll hear from your peers, and it will be very focused on the real problems that you have today. Participation is free and voluntary, as we said earlier. And there is an economic opportunity. There's a stipend that could be received or support that can be received, about up to $6,000 to compensate for the time that your staff will invest in attending these huddles. We imagine that over the course of the 16 weeks that we'll have somewhere between 3 and 4 staff persons from the nursing home, typically a CNA, an administrator, perhaps the director of nursing, in some instances the medical director. It'll vary by the nursing home, but some combination of those actors that will join each of the sessions and will learn together and we'll plan together and work to implement some of the changes that we'll describe. So how do you get involved? The trainings in this program, these webinars that we're doing right now are essentially recruitment and basically trying to give you a bit of a teaser as to what this will be like. We're trying to share with you some of the information that will immediately be useful to you. Alice will follow me in just a moment and we'll share a brief nugget of didactic and hopefully useful information. But the trainings, the formal 16-week curriculum will begin this month. And so if you're interested or your organization is interested, and the entire organization, by the way, if you're a multi-nursing home organization, you can sign up as a whole group, but sign up at the website that's on the slide, and that will be put into the chat as well. And if you have further questions, or there are staff that have further questions about this in your nursing home, please join a future webinar in which we'll recap some of what I've said here. And you can always contact us at the email on the slide, echonursingHome@salud.unm.edu. So please feel free to get involved. We look forward to welcoming you into this network, and and please feel free to ask us any of your questions now or in due course.
Well, good morning or good afternoon, wherever you are. My name is Alice Bonner, and I'm from the Institute for Healthcare Improvement. Today, we have a little nugget as part of our presentation we're calling How to Run an Effective Nursing Home Team Huddle. We know that for some of you, this is going to be review, that you're already working on team huddles or staff meetings, whatever you may call them. But we wanted to give a foundation for everyone who's going to be thinking about participating in Project ECHO. So our aim today is to provide information and resources on how to run an effective nursing home team huddle specific to COVID-19 infection prevention and management. We have a few learning objectives you can see here. We would like, after the end of the huddle, for people to be able to describe the huddle team members who come together, to list at least 2 characteristics of an effective huddle structure that's designed to promote strong relationships and address prevention and management of COVID-19, and to talk about the role specifically of certified nursing assistants and case studies. So what is a COVID-19 huddle specifically? Well, it's a brief, often just a 5 or a 15-minute meeting that's designed to share important information and updates about residents or care processes and workflow, in this case, related to COVID-19 prevention and management. A positive mutual exchange of information is needed in order to prevent the spread of COVID-19 within the nursing home and to safely manage residents with mild COVID-19 who may have elected not to go to the hospital or might not have reasons to go to the hospital. Huddles can be done anytime. Very often they're done at change of shift. They can be done in a conference room or as walk rounds. Walk rounds have been shown to be very effective, and that's where the entire team or the designated team goes and walks from resident to resident. Huddles can also be done with a change in resident condition, for example, someone who has become COVID positive, or with a change in staffing, and if there's a need to move staff around in a particular way, particularly direct care staff. Huddles can be done when there's a physician, nurse practitioner, or even a consultant for infectious disease who comes to the nursing home to see residents and advise about COVID-19 assessments and interactions or interventions. So huddles are a part of a comprehensive, systematic approach to reduce morbidity and mortality from COVID-19. So why are huddles often effective? Huddles, enable us to prioritize and to look at the education and skills training based on assessing how we're doing in a particular organization and figure out where there are gaps and opportunities. Huddles can reinforce teamwork and positive and productive relationships that can lead to action. And this is really important because we can't get anything done in our centers unless we have positive teamwork. Huddles enable staff to all hear about residents at the same time so they can provide appropriate care to each person, even people who are not on their assignments. But, providing the same message at the same time to everyone in the huddle means that those people can communicate consistently and reliably going forward. And huddles really provide an opportunity for critical thinking and problem solving, and they enable staff to share case studies, especially people who are at the point of care, especially certified nursing assistants in nursing homes. Really critical to hear what things are going on at the point of care and be able to bring that back to the entire team. So who might participate in COVID-19 huddles? And this varies a bit, but certainly nurses, CNAs, if you use medication technicians or assistants in your area, and anyone else who works directly with residents. It might be an infection preventionist, for example. That would be a very good person to include in the huddle because they have advanced training in how to approach COVID-19, very different aspects of the condition. Additional people are listed here on the slide. It might be the administrator, director of nursing, pharmacist, depending on what the issues are. And so these folks could come to some of the huddles, but not necessarily all of them. Very important to think about housekeeping, therapy, activities, because these are all influenced by the regulations and the guidance around COVID-19. So all staff should be invited to attend if they interact with residents. Think about the business office staff who maybe they go and they ask residents to sign forms or letters, for example, and contractors or vendors who are coming into the building, particularly if there's environmental issues related to COVID-19. So, again, contracted cleaning service because they're wondering about supplies and equipment and products to use, contracted laundry service, etc. And then determine how the feedback from residents and care partners will be integrated into the huddle structure. Very, very important because, as we said in the beginning, huddles are part of a comprehensive and systematic approach. So what might be included in a COVID-19 huddle specifically? Well, a resident-by-resident report with a focus on positive and negative COVID cases, anybody who's newly positive or has had a change in condition, change in medications, or other non-pharmacologic interventions that are being used. If there are admissions and discharges, wanting to know the COVID status of those residents, particularly new admissions, and updates related to testing protocols, cohorting, quarantining residents who come in who might need to be on quarantine for 14 days or for some period of time, isolating people who have tested positive. What's the availability of PPE in your area and other kinds of equipments or supplies you might need. And then thinking about staff return to work policies if people have been out because they have been COVID positive. On a huddle, you could share news or updates from any department related to COVID-19 and think about non-clinical departments because cleaning and disinfecting are significant areas of review. Checking in on new employees, agency employees, anyone who needs COVID-19 knowledge and skills, which is pretty much everyone. Communicating with family members or care partners and following up from previous conversations with those individuals. People are very anxious about COVID-19. They're looking for information to help them get through, just as we all are. A couple of huddle basics, and again, I know that a lot of this is, you know this information already, but we want to start and end on time. We want to set expectations from the beginning so that staff are aware what's expected of them during a huddle. And we want to have action and solution-focused huddles based on the experiences that people have with residents and what they know about COVID-19. A couple of basic agreements, sometimes people call these ground rules, but basic agreements about how to engage during huddles. We have an all teach, all learn philosophy. We want people to be thinking and open-minded and listening to one another. We want them to practice both and approaches to new ideas. So if I have an idea and then you have an idea that sounds really different, we want to say yes and or both and thinking to help ideas become free and open to be discussed and not shoot down anybody's ideas during a huddle. We want huddles to be positive and open. We want to avoid any jargon or acronyms that people might not understand. We want to both speak up ourselves and give others a chance to speak. We want to make sure no one monopolizes the conversation. And we want each person on the team to be equally valued and feel that very much. Regardless of anyone's role, everyone is equally valued. And the huddles, as we said, should be supportive and positive and seen as valuable by the people participating. So, in wrapping up here, what motivates us to want to engage in huddles as part of our system of care and part of Project ECHO? We really want to stay focused on our mission and our vision, which is preventing morbidity and mortality from COVID-19 for residents, for staff or team members, and to reduce rates of transmission in the community. In long-term care centers, they make up 8% of all COVID cases, but 40% of all COVID deaths. And in your state, it may be higher than that, but that's the national average. We want to understand each team member in their role or job. We want to identify challenges and barriers and test solutions together. We want to be action solution focused. And we want to increase rapport and trust among team members and between staff and residents. Residents and their care partners and people in the community are understandably concerned because there's so much uncertainty with COVID-19. So the huddles specifically need to address what we know to be the case and the evidence so far, what we don't know at all, and where there's a gray area in between where we know some things but not necessarily everything that we need to make decisions. And we want to be transparent about that. So ultimately, we want to build on our strengths and what we've already accomplished together as a team. And we want to celebrate and reward successes, and there are many of them out there. So we want to thank you for all the work you do every day. We know people are working extremely hard, and we encourage you to contact us if you have any questions about the presentation today. Here are some resources that we put together for you. Some are from PHI, some are from the QIO. A lot of the information today was based on work by the QIOs and the Pioneer Network. And finally, these are some resources from the CDC, and we strongly encourage you to take a look at these as well. Thank you very much.
All right, very good. So this was just a very brief example of the type of guidance that will be available during the 16-week curriculum. We are at time, and we would like to thank everyone on the network for attending today's session, for sending us your questions. for further information or questions that we weren't able to get to today, please visit us at the website that will be posted in the chat box, or email us at the address posted in the chat box. And thank you again, and we look forward to working together over the coming months. Thank you. Bye.